This is the recording of the Getting Closer to Balance webinar organized by the Center of Research for Non-Communicable Diseases, Faculty of Medicine and Health Sciences that took place on the 17th of April.
Okay, good morning all respected dignitaries, students across the globe. This morning, the world looks so small, participants all over across the globe. We'll start the seminar officially in a short while. Allow me to introduce myself. My name is Tarun Amalekar. I'm a lecturer in the Department of Physiotherapy in Faculty of Medicine and Health Sciences at University Tunku Abdul Rahman. I'm a lecturer in physiotherapy. We are from University Tunku Abdul Rahman, a premier digital technical university and a global university, which is ranked between 500 to 600 in time higher education, world university ranking, and 157th in QS Asia University ranking under the Faculty of Medicine and Health Sciences, under the patronage of Center of Research on Non-Communicable Disease, CRNCD, would like to welcome you all and would like to say good morning again. Few basic house rules. This session will be recorded by organizing committee. You are requested not to record this session on your devices. Please turn off all the mics and videos. If you have any question, please type them into the right chat box, preferably with the name of the speaker in particular or whom you wish to listen upon. In case of any technical issue, please do send an individual or a private chat message to Ms. Wali on the email vevalev@utar.edu.my directly, and she will get back to you as soon as possible on the matter concern. At the end of the seminar, at the end of the concept, we'll be provided with a link to share your feedback, and you are requested to fill in the same, as only upon filling up the form, you will be receiving the copy of certificate. This will be our webinar schedule and related details. We have started the event by 10. We will have our first speaker in a short while, and we tentatively will complete this whole endeavor by 2 o'clock. Once again, a warm welcome and thank you all for joining us this morning to officially inaugurate the whole event, or I should say a seminar. Hereby is the message from Emeritus Prof. Dr. Chong Sun Keng, FMHS Dean, University Tunku Abdul Rahman, for you.
Good morning, ladies and gentlemen. Welcome to this seminar entitled Getting Closer to Balance, organized by the Center for Research in Non-Communicable Disease. It is timely for the center to pay attention to this neglected area about balance, which is so vital to our day-to-day well-being. We have a panel of experts from Singapore, India, and as well as from our UTAR staff to explore this field based on evidence, especially the lesser and emerging area on cognition, fear, and vestibular system contributing to balance. So hope you enjoy this seminar. Thank you very much.
We are going through unprecedented and uncomfortable time of social isolation due to COVID-19 pandemic. I must say, we are still trying our best to keep up us updated and learn in this phase of life also. We are using various platforms, and online platform is one of those. We can explore, listen, and learn from the esteemed researchers. Today, we all have gathered to listen from experts on novel notions, distinctive approaches to handle a very commonly encountered and often ignored in the field of physiotherapy, where we can see a lot other attributes also, that is we call as balance. It's a great opportunity for all of us to pick up the pearl of knowledge throughout this endeavor that covers a variety of concepts such as vestibular screening, treatment, research and data for clinicians and students, and some relatively unexplored areas of attributes, confidence, fear, and other psychological factors that may affect a balance of an individual. We assure that we have something for everyone and we will be amusing you through this engross and whole endeavor. So without further ado, I will request first speaker of the day, Prof. Raj, for coming on the screen. Prof. Raj is head of the Physiotherapy Department in Yanapoya, deemed to be University, Mangalore, India. Prof. Raj has qualified his master's in physiotherapy, which specialized in neurological and psychosomatic disorders, and is recipient of a prestigious gold medal during his studies. Currently, he is at the edge of completing his pursuing his PhD. He is on the edge of completing his PhD in physiotherapy from lovely Professional University, Punjab, India. He has a vast experience that stands for 19 years, and his teaching experience and other conceptualization are across the globe. He has served in Malaysia and also in India. He has also served as clinical therapist, as a chief therapist for a tenure of 6 years. He has conducted numerous researches and also workshops, and I was finding pragmatically difficult to select some of those, but I will have those across Malaysia and India since 2006. Some of the honorable mentions are research methodology, biostatistics, concepts of electrophysiology, neurology outcome measures, and research in neurological physiotherapy. He was also honored by Indian Association of Physiotherapists for his successful contribution in the field of physiotherapy. He has rendered his service for 10 years in Malaysia at Masa University as a lecturer initially and thereafter program leader, head of the Physiotherapy Department and deputy dean. Currently, he is serving as professor and research coordinator at Yanapoya Physiotherapy College, Yanapoya, deemed to be University, Karnataka, India. And easily approachable, and personally also have felt that an ever-ready educator. He is very popular among his student and physiotherapy fraternity for tremendous research knowledge, as well as his administrative as an efficient leader. Now request Prof. Raj to share his slide. Prof. Raj, you may start now.
Thank you, Mr. Tarun. Thanks for that nice bit of introduction. I'm very privileged and really glad enough. Am I audible?
Yes, you're audible.
Okay, thank you. I'm really privileged and glad enough to be a speaker for the seminar or for this webinar organized by the UTAR Malaysia. So I'm here to talk regarding the updates in balance. So shall I start sharing? Mr. Tarun, shall I start sharing?
Yes, Prof. Raj, you can start now.
Okay, thank you.
Thank you.
Okay, good morning, everyone. So today we are going to look at something very familiar that everybody talks about, balance. The topic of the webinar itself is like quite interesting because we are trying to get closer to balance. In a way, we are trying to know more about it. So the topic that has been given to me is updates in balance and what is the evidence today. By means of this, it's not that like I'm going to talk only about the research evidence. I'm just going to introduce you with the concept of balance and how it is integrally controlling the whole body. And then we are also going to look at what are the elements of it, and what could be the recent updates in its mechanism, or say about the assessment or about the intervention strategies. So with that note, I would like to go ahead with my presentation. So I think you all could be seeing these pictures. Is that every one of us should be achieving in our real life? Possibly, yes, but over here, all of them have taken it up as their profession or as their passion or as their achievements, whatever we could say. Of course, it is a balance act. It is an act that requires tremendous amount of control in their posture and balance. Without that, they wouldn't have been able to achieve these positions that we have wonderfully photographed and viewing and enjoying it. We are not about training this balance for every individual. We are not speaking about that, but rather we are talking about that essential balance that the human being should be having in their everyday life. Balance is a big question mark. So what is this all about? You have got variety of terminologies describing it, given by various medical dictionaries. And the researches that has been done on this extensively have brought in a lot of clarity in a way that we are looking at it. The integral component, we could say the balance as, or it is a complex phenomenon. Yes, it has got every bit of elements in it. Say it could be sensory, it could be motor, or it could be processed at the central, it could be taken to the periphery. Whatever way you want to say, it's a very, very integral component, and it's a very, very complex phenomenon. Of course, yes, there are certain pathways that have been identified to talk about how this balance is happening within our body. There are sensory inputs and there are motor outputs. Automatic postural adjustments, as everyone could describe it. And this postural adjustments is not happening just like that. It is happening with the inputs of sensory information. You're able to sit and listen to me. For that sitting position, you require balance, which we define as a static balance. And we need to get up and walk around, do our function. We need to have dynamic balance. So these automatic postural adjustments with inputs of sensory information is constituting our balance that we require for our everyday activity or our normal functioning. And it deals with internal and external perturbations. What do we call these perturbations as? Perturbations are those disturbances that could alter our body mechanism. It could bring out the body responses, and it promotes the strategies to function and bring in the balance that we are expecting to happen so that we can maintain the body's center of mass over its base of support. If you want to define balance of any object, we generally call it as it is the ability to maintain the center of mass or the center of gravity or the line of gravity within the base of support. And of course, by balance, we are able to do two main things. One is postural orientation, the other one is postural equilibrium. What is this orientation? It is the alignment of our body. It is the alignment of the different structures of the body so that we are able to maintain our position in whatever we are adapting to. And our position is not stagnant. It keeps changing. It keeps modifying for every bit of actions that we do. So we do require orientation in our every phase of movements. Say it could be a static one or a dynamic one. It could be for a functional one, or it could be for any other ways that our body wanted it to be. It can be for a sport performance, or it can be for a dance performance, or it can be for any kind of performance that we would like to showcase. Hence, I was telling that the posturation as well as the postural equilibrium becomes an important component of the balance. So in a way, Hans in 2006 said that postural control can also be used synonymously for the balance. And yes, here we have the sensory input, we have the motor output, and then we have the mechanisms that is happening that is bringing out the balance in our body. When I say the sensory input, three of the very important systems are acting on it. Without the efficiency of these systems, the balance cannot be brought in what we are having in our body. Number one is a vestibular system. Number two is a visual system. And number three is a proprioceptive system. Of all the three systems, each of them has got its own percentage of contribution in different forms of balance that we are trying to showcase in our everyday activity. And that also I'm going to present it to you in the form of update, because many researchers have contributed in order to identify what amount of sensory input is being it is coming out from each of these systems. Say it could be vestibular, or it could be visual, or it could be proprioceptive. So the vestibular offers equilibrium, the vestibular offers spatial awareness, rotation movements of our head on the neck, and the vision it controls in a linear movement. And not only that, it helps to maintain the body, during any kind of disturbances in erect posture. The visual input is also equally important. If there is no proper visual input, we won't be able to have a proper balance, and that could have a compromise. And the proprioceptive is, of course, the input that we get from those proprioceptors, the muscle tendons, the Golgi tendon organs, is very, very important. That is helping us to realize and correct our posture, and we are able to avoid the falls that could happen otherwise. And all these are giving their input to the cerebellum, which is also processed at the cerebral cortex, and that gives a proper motor output, which is able to control the body movements. And not only that, even the basal ganglia has its role. Even the brainstem has its role, because it is integrating and sorting out what is the necessary sensory information that is required for the balance of our body. So that gives out the vestibular ocular reflex and other reflexes that is mainly brought about by the vestibular input, and it is able to bring in the motor impulses of the eye movements that is mainly possible because of the visual input. And it is also bringing out the motor impulses, which is mainly responsible by the proprioceptive or the somatosensory informations. And that gives the balance as a whole. Sorry. Okay, so now in terms of balance, we have these pictures that can very clearly show you a static balance and a dynamic balance. What is meant by static balance? It is the ability to maintain the postural stability and orientation with center of mass over the base of support and body at rest. Here you must understand any balance, whether it is static or dynamic, that will try to maintain the postural stability, and it will make us get oriented with our center of mass over the base of support. I'm ideally using the term center of mass. We can also be using center of gravity, because most of the time the center of mass will be equal, or it will be at the same position at the center of gravity. But when the objects become larger and larger, the center of gravity is slightly pulled downwards. I believe you all must be knowing, because the physics says that as the objects becomes larger, center of gravity is tending to move towards the most heavier or the most lower part of that particular object. So whether it could be center of mass or it could be the center of gravity, it needs to be brought in over the base of support. Otherwise, our postural stability is not going to be there. And this static balance, as described by Sullivan, is the body's balance at rest. Whereas the dynamic balance, if you could see, it is the ability to maintain the postural stability as well as the orientation with center of mass over the base of support while the body parts are in motion. So in the previous static balance, we were talking about when it's at rest. Now we are talking about when it is in motion. Say our any form of movements, if I want to sit, if I want to sit from the bed, if I want to stand from the sitting position, if I want to walk, if I want to run, everything is being controlled by this dynamic balance. So when I say static balance, it is the steady state. When I say dynamic balance, body is bringing in two different forms of actions. One is proactive response, the other one is reactive response. What is this proactive? Most of the time, we are able to know what perturbations or what is the disturbance that can happen to our body. For any normal human being, we are talking about the body's responses to anticipatory perturbations. What does it mean? When I say anticipatory, you are able to guess, yes, there is going to be a change, and I'm going to do the adjustments. And that becomes proactive. And it happens so quickly that we may not be able to identify how you have performed it. So basically, these anticipatory perturbations are smaller amount of changes that is brought in by our body for any kind of, the adjustments that we know by conscious. We are able to interpret. Whereas the reactive form of dynamic balance, you are not able to expect what kind of changes is going to come in on your way. Say, for example, why the elderlies have a fall. That is because they haven't expected that perturbations that has come across in their way, and the body's mechanism to adjust to that unexpected perturbations is not happening, and that's why a person is having a fall. It's as simple as that. So as we grow, the body's mechanisms of getting the sensory input, the body's mechanism of processing it, the body's mechanism of bringing out the learned movements from the cognitive aspects, and the body's mechanism of putting out in a motor output is slowly getting deteriorated. Why it is getting deteriorated? Because we are not putting those responses into our everyday action. In a way, we are not nurturing them. We are not training it. So that is why when there is an unexpected perturbations, all this input is not giving out the response that we are expecting, which could otherwise happen in a normal manner. I hope you people are able to get it. So with this amount of note on the basics of the balance, I would like to move on to the updates. In today's evidence, in today's world, how the balance is seen, or what kind of evolutions has happened in the term of understanding the balance in its integral component. When we speak about the static balance, of course, yes, it is the body's responses in the steady state. But whether all these sensory inputs are being equal in their contribution, study shows that there is variations, whether it could be a static balance or it could be a dynamic balance. The research by Alcock et al., which was done recently in 2018, indicates that the static balance has got the most amount of input by proprioceptive stimuli rather than vestibular or visual stimuli. If you could see, for our static position, the feel of the position is very, very important. So the proprioceptors plays an important role and makes the body understand how it is aligned or how the postural stability is required by us. And thereby it brings in equilibrium, bringing out the balance of the whole body. So when I say static, it's mostly proprioceptive. And of course, vestibular takes the next position by giving out the 20% of component and the static, 20% of the input, and the static takes, the visual takes in 10%, which is very, very minimum for this static balance. Of course, if you could think in a broader aspect, you don't require that much of visual stimuli when you are fixed to a surface that's not moving or you are not moving. Either ways, the visual stimuli is not going to have a compromise in your state or in your steady state. That's why the researcher shows that if you could train those proprioceptors in terms of people getting compromised with the static balance, in case of spinal cord injuries where they are not able to maintain their positions, if you could train the proprioceptive input, it automatically regains the balance that could make them independent to a certain extent. And if you could see the dynamic balance which contributes the body's responses, the vestibular plays the most important role in bringing out the dynamic balance. That is around 60% of the input is given by the dynamic balance. Whereas the 30% is by the visual and the least is by the proprioceptor. You can understand the body is in motion. When the body is in motion, the contact is not happening constantly. So the proprioceptor's role is not so evident over there that you can very, very easily identify. Whereas the visual stimuli, the gaze stabilization, or it could be the gaze shifting. Over here, the visual stimuli is the responsible mechanism for these two, gaze stabilization and gaze shifting. In gaze stabilization, we are trying to fix our image that we need to follow during our motions. Whereas in gaze, in gaze stabilization, it is mainly the visual input that is getting stabilized and we are in motion. In gaze shifting, the eye is also in movement and we are trying to fix the image. Whereas vestibular brings in lots of postural responses in terms of fixing our trunk on the limbs, in terms of controlling the head movements with reference to the viscera or with reference to the external stimuli. That is very, very important. So during our dynamic activities, it is mainly the vestibular stimuli that is giving lots of contribution rather than the visual or the somatosensory. Of course, visual takes the second position and the somatosensory or the proprioceptive input takes the last position. And in assessments, you would have been hearing about lots of scales that is coming in line with the assessment of balance. But the review done by Alonso et al. In 2017 have identified the balance specific scales in 3 different categories and have found the good amount of reliability and validity with these 3 scales in their systematic review. And if you could see, I'm not including those scales that is, coming in terms of balance confidence or, the fear of fall, which Madam Maha is going to touch later. And I've not included the vestibular assessment except the one at the equipment site, because you have Associate Prof. Sengvi to talk about that. So in order to avoid the overlapping, I have listed those scales that can be categorized for your clinical assessment that could be used as, the scales for both the patients or the caretaker and the equipments that could easily assess the balance within no seconds. You would have heard about timed up and go test, unipodal stance test, Romberg's test, functional reach test, which are there, for a very long time, and it is very well in practice, which we categorize in terms of functional balance, or clinically, we could use them on all our patients as per the requirement. Whereas the scales is, quantifying the work, the balance activity in different forms of activities. In work balance scale, we have got 14 items and it has been modified into 7 items. And we have got the postural assessment scale, which is talking about the postural alignment. And we have those balance intensity scale, which is assessing the intensity of balance that the individual could, put in as an output. And this is helping both the exercisers to assess as well as the person who is exercising to assess himself. And we have got the dynamic gait index, which is exclusively measuring the gait in terms of dynamic balance. And then we have got the equipment that has evolved in these years with lots of latest technology. You have got those force platforms, which measures the force that we are able to exert in all the 3 important directions: anteroposterior, medial lateral, and vertical. The Biodex balance system is able to assess the balance in its integral form, and we are able to understand how this patient will behave in different forms of perturbations. We have this posturography, or in a way it is called as equi-test, which looks at the postural alignment and the postural equilibrium. And we have got this video nystagmography, which is a vestibular form of assessment that could give us a very clear understanding on the input of the vestibular system and how we are able to bring in the response, or is there a delay in it. So, with that note on assessments, which I will be presenting you in our next session, some of the research articles that has looked into it. And now moving on to the intervention strategies. We have got balance training with anticipatory adjustments, and we have got reactive balance training with unexpected perturbations. Most of the time, we are trying to train our patients with anticipatory adjustments, meaning the patient knows what kind of adjustments I need to be doing. If you are asking him to go for a tandem walking, what he does, he walks. So he knows when he lifts one foot and keeps in front of the other foot, he will know the pattern of adjustments that he needs to bring in, whether at the ankle or at the hip, in terms of the change in the perturbations. Or he will be able enough to understand whether he has to go for a fixed support or a change in support. So these adjustments are anticipated. But in our daily activity, the adjustments or the perturbations doesn't happen as we expect. It happens unexpected. There may be any kind of stone on the way which you didn't expect. It could be smaller or it could be bigger. It could be the surface could be slippery. The surface could be smooth enough. The surface could be hard enough. And how are we going to adjust to all those unexpected perturbations? That training is known as reactive balance training. And balance training with anticipatory adjustments, even the star excursion balance test, where we are trying to move one leg in different directions, it is an anticipatory adjustments. Whereas the unexpected perturbations cannot be brought in with our conventional form of training. Yes, of course, the therapist can try to alter the amount of resistance that he is trying to give by means of a belt or by means of a TheraBand, and thereby give a form of reactive balance training. But the balance tutor system, the advanced equipments are clearly focusing on it, or the proprioreactive balance system, which is training a person in terms of the change in support or in terms of altering the body's the patients and the body's responses are not, the same way as expected every time. So with that information, I would like to show you a video on the balance training with anticipatory adjustments, followed by the balance training with a reactive form of training. So here we go. Let me first so you can see over here, it is not the expected perturbation that has happened. It is an unexpected perturbation due to that wire on the pathway. So here we are able to understand the perturbation, the distribution of the perturbation in terms of percentage and how the patient is reacting, the time that is required, the perturbation interval, the compensatory steps, everything is measured in detail so that
Raj, sorry to hinder, is it you're sharing the audio also?
So the one that you saw just now is for the reactive form of balance training. And the one that I'm going to show now is for the anticipatory adjustments. So let me go to that now. Sorry. I think I should share my screen.
Prof. Raj, we can't
Yes.
see you.
Yeah, I'm just trying to share the other video. Sorry, 1 second.
Thank you.
Sorry for the delay. you can view this. In this, the person is trying to do the changes by, touching the one that glows the lights up.
Prof. Raj, sorry to bother you, but we cannot see the screen. We cannot see a
It's
screen.
not sharing.
Yeah, it's not shared maybe.
Are you able to view now?
We can see the first slide, I think, the title.
Now? Now are you able to see the screen?
Yes, we can see, but we cannot see the recent, like the one which you were discussing earlier. After
Pardon?
type of balance. After type of balance, we cannot see that, like, I think it's stuck somewhere.
What about now?
Yeah, we can see now.
You can see that. Sorry for the technical disturbance. So this is a quite anticipated, the reactions, the body's anticipatory adjustments in different directions. That was the one which I was trying to make you understand in terms of reactive balance training and proactive balance training. So with that note, I would like to, are you able to see my slides now?
Yes, Prof.
Thank you. So these are some of the balance equipments in terms of rocker board. You have got the balance cushions, the balance pad, or even you've got the Bose ball trainer, or the Swiss ball, the balance foam, or the rocker board, or the wobble board, and the balance master. And these are my references. Thank you. I hope I'm on time. Any questions?
Prof, we will take the questions at the end of the discussion from all the respected speakers. Allow me to share. Maybe you have to stop sharing the screen. Sorry.
Definitely. Thank you very much. Thanks for the patience. I'll be coming back again. Stay connected.
Okay. Thank you, Prof. Raj, for those important updates and information. I do have some questions on my own also, but with respect to the time, we'll have the questions and we'll take those questions in the end of the session. But just would like to convey our sincere thanks that you have incorporated so many concepts such as those important studies of proactive and reactive balance training are very important part of physiotherapy rehab. Maybe some questions we are pondering upon, but we'll go our valued participants. So thanks again. You brought us back to the anatomy and shared also the important updates, what is happening and like what was in 2017, 18, which is quite recent for us to see a varied aspect. So thank you for those. We will have Prof. Raj again, and thank you for the session, Prof. So without further ado, we'll go to the next session. Maybe Prof. Raj, I will request you to Stop sharing the screen. We'll have Miss Mahadevi now. Okay, Miss Mahadevi Bharati, senior lecturer from Department of Physiotherapy, FMHS, University Tunku Abdul Rahman. Ms. Madhavi has been practicing as physiotherapist since a long time, 1995. Somewhere I was in schools that time. She has initially started her practice in Singapore, in second largest hospital, whereby she was involved in conception, expediency of clinical practice, management, and training. She has completed her master's in the field of physiotherapy. I'll share those details further. From Curtin University of Technology in Australia, she is specialized in neuro rehab. She was also awarded with a renowned fellowship in Parkinson's disease by Singapore Ministry of Health. That was something like to ponder upon. For the past 10 years in Malaysia, she has commenced as private physiotherapy practitioner, and then having a vast clinical experience, has also explored and ventured into teaching, being a lecturer in prestigious and well-known university. Names are UCAM and MASA. Now she is with us. She was also deputy head of School of Physiotherapy in MASA University. Throughout her career, she has been involved in training, education for both students and what we call training for the trainers. So she was also involved with training the physiotherapists, clinical therapists. She has contributed on various platforms such as national and international concepts. She was a part of organizing committee. She has been called upon as speaker, facilitator on numerous events, workshops, seminar, and lectures. Her passion has been her mainstay, and in fact, like this whole concept is her brainchild. So without further ado, I would request Ms. Mahadevi for sharing her slides.
Okay. Thank you for the most. Are you able to hear me?
Yeah, we can
Okay.
hear you well. Yeah.
Yes. Next time, please remind me to maybe block out the year, so people cannot be counting my age.
Okay, but that was something like I found. Yeah, okay, I'll take note.
Okay, let me just pop up my slides. So I live in Malaysia near the airport, and our internet connection sometimes goes slightly up and down. So please bear with me if I'm going in and out. Can you, Mr. Tarun?
Yes, yes, Ms. Maha, we can see the slide.
Okay. First, welcome everyone to our second webinar, actually. Rightfully from the Physio Department, our fourth webinar. And I would like to thank my speakers and close personal friends as well, Prof. Raj and Prof. Wee Seng Kui. I pause at their names because, normally I'm calling them differently. But for these reasons, I have to use the correct designation. Okay, talk today, the other side of balance. So all of us, I hope all of us have seen Justice League. If you haven't, please catch it. So some of us will know that probably one person is missing in the Justice League in the movies, and the same thing with the other side of balance. There's a big question mark here that people know about it, or they are maybe ignoring it, or they want to know more about it. Evidence is still coming up on all these other sides of balance that we should know about. So what are the components of balance? We've heard actually from Prof. Raj, all the different components. So there's loads of components, right? Which means that if we want to know balance well, we have to assess all these components in some way or the other. So what exactly is good balance? So again, Prof. Raj has told you a bit about it. This is the definition act of maintaining, achieving, or restoring a state of balance during any posture and any activity. So physiotherapists and balance actually, they are very good friends. Yeah, right. Our whole assessment is about balance. Our whole treatment is about balance. You know, we're just very close to balance. So which means, right, we're doing a lot of assessment, a lot of treatment. We're doing sitting, standing balance. We're doing management. We've got a whole lot of tests for balance, right? If you ask a class of any students, they can give you 5 or 6 tests on balance. So physios and balance. But do physios actually know about balance, right? Are they working well with balance, right? So this is the other side. There are some gaps, there are some gaps in our knowledge which has just recently been filled up, and there are some gaps in our practices as well because we have not caught up with the knowledge, right? Now, this is studies done by in Canada. It seems a lot of studies on fear of balance and all that, fear of falls is coming from Canada. Maybe it's very always fearing falling, I'm not sure. But yes, so anyway, they found number one for physios, they did a survey on all physios, and the physios themselves are saying that they're lacking knowledge in proper assessment. And they're also saying that their balance assessment is on physical aspects, and the cognitive processing is the least assessed. Okay, so this is the gap, and this is the gap that I will be sharing with you a little bit. We've only got half an hour, so just the tip of the iceberg I'll be sharing with you today. So what is the gap that I'm sharing? Basically looking at cognition and balance, the fear of falling and balance, and the confidence of doing an activity and balance. But please remember, this is not the only gap, okay? Please don't say, oh, good, the gap is filled. We still have a lot of researching and a lot of training to do. Okay, so what exactly is the fear of falling? So 9 out of 10 times, whenever I run a class and I ask them, why do you think this person cannot stand up? Definitely one of the answers will be fear of falling. But if I ask the student, okay, what do you mean by fear? What are? Then the answer stops there because they're not sure what exactly they're fearing. They know they're fearing falling, but they don't know what exactly is that. Okay, so fear of falling is a persistent feeling related to the risk of falling during one or more activities of daily living. That means you're doing something, but you have this constant fear. Oh no, I'm going to fall. Oh no, I'm going to fall. It's the same if you remember back long time ago when you first started driving. That constant fear that, oh, please don't let me change lanes. Oh, please don't let me change lanes. Yeah, so that was the biggest fear when I was driving before. Now, there's another thing called false efficacy. Okay, and we thought it's the same. Yeah, a lot of times I thought it's the same, but as they're researching more, they're separating it, and it seems to bring about different results. So false efficacy is the belief that one is able to maintain the balance. So false efficacy is the confidence that I have to maintain my balance. Fear of falling is the fear that I have that I will fall. False efficacy is the confidence that I have I will not fall. You see, so there's a slight difference there. And what they found is actually this effect can lead to different consequences. Okay, so this is how we start out balancing in our very early years, right? No fear, we'll do anything we want, or the parents will be the one most fearful. Okay, as we grow older, we develop some healthy fear. You can see her arms going up a bit, so she's fearing a little. Okay, then somehow, we've learned to balance and we're full of confidence, we can do anything we want. And then this happens. Okay, white chalk marks on the beam balance, already the soles of your feet are sweating, right? So I came across this. Today I noticed while on my walk, I could walk on a 6-inch border on the ground without falling off. But I have never been able to balance on a balance beam. The fear of falling is very powerful. And that is very true, isn't it? All of you will be able to walk on the ground, exactly on this balance beam, which is on the ground. No problems at all, right? But if I move this up 1 meter above the ground, then suddenly you cannot balance. And that is the fear of falling, to put it a little bit into perspective. A few levels lesser, I would say, where this fear that you feel on the balance beam, they feel when they're doing maybe sit to stand or walking. Okay, so that's a perspective you should be thinking about. Now, what's the prevalence? So again, this evidence is ongoing. In Malaysia, we haven't yet looked at it. So anyone going for your master's or your PhD, this is area. Mr. Raj will probably cover some of that as well. So the fear of falling, there's a range, 50 to 60% of people who have fallen report fear of falling. And out of this 50 to 60, about 25% or more say that they will avoid doing activities. And there's also some excessive fear of falling. They've called it post-fall syndrome. In 1982, it was coined, but we're not using it too much actually. So this is actually a large amount of activity restriction, loss of independence, than the physical injuries that they actually have, the limitation. So the fear of falling, please remember, fear of falling also can occur in people who have not fallen before. Okay, so there's a certain percentage of people who have never fallen before and they have a fear of falling. Okay, so why do we fear? Why should physios fear of falling? So this is the thing. If we haven't been assessing the fear of falling, we should start assessing the fear of falling. Okay, so this is the difference between your patient who you've done everything, you've done the works, you've done your strengthening, you go all around the gym, he's almost 1,000 around the gym, but the moment he walks out the door, he's on a quad stick or a walking frame. He doesn't go out of the house, he doesn't go to the coffee shop to see his friends, and there's a huge disparity there. Okay, and that one of the reasons could be the fear of falling, actually, right? Now, fear of falling has been shown to be predictive of future falls. It has been shown if someone has a high fear of falling, it has been predictive of future falls. They've shown that they've got definitely decreased dynamic standing balance, and very directly they've shown someone who's got fear of falling has got impaired gait. And what they're saying is that they have this impaired gait is because they have this fear, so they're tightening unnecessarily some muscles, they're reducing some range, reducing unnecessarily, not because the body cannot, but because they have this fear. Okay, and of course they'll avoid activities. And we know that once you avoid activities, it spirals down to a vicious cycle. You have your fall leading to less activity, leading to decreased muscle strength and balance, fear of falling again, and increased risk of falling. Okay, now the fear of falling has three components to it. Okay, they have identified there's a cognitive component, a behavioral component, and a physiological component. The cognitive component is when there is a fear of falling and you're avoiding you have, sorry, let me repeat that. The cognitive component is when you have some limitation, maybe you're a bit weak, your hips are a bit weak, your legs are a bit weak, so you're a bit careful. You're careful about some of the activities that you do, so you're actively being careful about certain activities. So that's the cognitive component. Now, the behavioral component is when you're changing all your activities, you're avoiding your activities because of that fear. Okay, so you're changing your behavior, not because there is a limitation, but because you have a fear. Now, physiological things like autonomic functions like blood pressure, hypoglycemia. So all these are physiological functions that leads to some fear of falling. So what happens, how we assess, these constructs, the cognitive part will normally be assessed by such things as a falls efficacy test, and the behavioral construct will be assessed by the fear of falling. So the cognitive aspect leads to or is linked to your confidence of doing your activities, and the behavioral aspect is linked. Okay, I'll tell you a little bit more about it a bit more. So they've divided this so-called fear of falling into two. Okay, so one is a false efficacy, so your confidence, and one is your fear, right? And they have also said how we can assess these two. Now, please remember, this is the starting of some evidence. So all this dividing into these two constructs has started in about 2018 by a group of researchers, mainly from Canada. So what are Canada, and there is a follow-up group with China, which is linked to this Canadian and American group. So they're all starting, all the references are in my references later on. So what they have started saying is that a specific balance test, activity specific balance confidence test, that assesses false efficacy and confidence. And the fear of falling uh, can actually be assessed by another test called the survey activities and fear of falling. You may have heard of ABC, but never heard of SAFE, right? Yes, uh, that's quite common. Now, the ABC test is basically, it will ask you the question, how confident are you that you will not lose your balance when you walk around the house, walk up and down the stairs, bend over and pick up? So this is and there's a few more, there's a 16 items on it. And it's a self-rating questionnaire. The patient answers themselves, and it has been translated to some languages, I think Chinese, if I'm not mistaken. Okay, so it will show us how confident you are at doing these things. So there's another one called the false efficacy test. Let me just come back to that. So SAFE is actually how fearful are you of falling during these activities? So this is a question, how fearful are you of falling during these activities? So there's a list of 11 questions. Now, SAFE was devised in 1998. Okay, so this is the history, a little bit of history here. SAFE was devised in 1998, after which the ABC was devised. Okay, how confident in you. Then people started liking this ABC. Oh, okay, this looks good, easy to mark and all that. And then they devised the FES, Functional Efficacy Scale. Now, Functional Efficacy Scale, when it first started, was similar to the ABC test. Then a group of European researchers decided to improve the Functional Efficacy Scale and called it Functional Efficacy Scale International. FESI. Now, what they did was they added a few more confidence that included the fear of falling questions, you know. So this FES1 has questions on confidence. How confident are you doing these activities? And has questions on fear of falling. How fearful are you of falling during these activities? Okay, so this even comes up, right? And as I said, this sorting all this out is still going on with the researchers now. Some of you may, you know, this is an area which you can touch upon and move forward with it as well. Okay, so the Canadian researchers have said, so FES1 it's a little bit confusing which one it is actually assessing. Is it assessing confidence or is it assessing the fear? Okay, so this is some of the questions, and you see they are asking you same thing, how concerned, how fearful, same question, right? So these are the things that are added that kind of mixes up the FES International for now. Okay, now the other thing is, now people with low self-efficacy, low confidence may also have fearful, may also be very fearful. So they'll have both. Okay, so that's another thing that we have to keep in mind. Now, why are we concerned, whether it's fear of falling, whether it's confidence? Why people are not moving? Because they are fearful. So this is the thing. So what the researchers have said is that if you assess wrongly, it can lead to inappropriate treatment. You know, it may assess the wrong impairments, and you may be using inappropriate assessment. You may be using the wrong assessment for an impairment that the person has. You know, wrong treatments can lead to goals not being met, and treatment outcomes will not be improving if you're assessing something and you're treating something else. We all know this problem, isn't it? So what we have to do is, there's nothing absolutely conclusive for now. There are introductory supplementary suggestions that they have made. Okay, so you have to watch this space, you have to gather more information, and this is an area you may want to go into as well. Okay, so let's talk a little bit more fear of falling. Now, please remember, it also happens in people who have not fallen before. Now, as I said before, it's predictive of future falls. It has been shown to lead to social isolation, depression, impaired gait, they avoid activities. The vicious cycle leads to muscle weakness, decreased endurance, postural hypotension, muscle joint stiffness, and decreased quality of life. And this is very itself, he can be the strongest guy around, but the fear itself will lead to all of these things. So let's do what we do best. Okay, here we go. So you see this gentleman here, obviously the physio has been very good, has had a hip fracture, physio has trained him up, has done balance, has done this and that, and look at him now, he throws away his walking sticks, and there he goes. Okay, so what have we done? So basically, why this guy manages to do it is because he's got no fear of falling. The physio has done a very good job on all the physical aspects or other, like for instance, vestibular aspects, if there's needed, has done a good job. So he's able to go on to his dancing. And because he has had no fear of falling, he's managed to do what he wants to do. So not all our patients are like that. Right? Lots of us have seen patients with neck or femur fractures, but not all of them are going back to what they were doing before. Management of the fear of falling is actually multifactorial. Physios will normally hit the MS, neuro impairment management, things like muscle tightness, muscle weakness, joint stiffness, all those things. And you will also do functional training, which we are very good at. Now, some other areas that people have started looking at is also nutrition. Nutrition has to be well maintained because with the elderly, a drop in nutrition level can mean a drop in functional level. Sleep has to be looked into, psychosocial issues has to be looked into, and one last thing there is cognitive. They've started some work on it as well for maybe about the last 5-6 years. More has been done, and they have found that incorporating cognitive behavioral therapy into the management of fear of falling has been shown to be quite promising. Okay, now these are some of the things that I've actually extracted from one of these Canadian researchers. She's done a talk before. So this is one aspect that physios definitely don't look at. You see, I had a fall at the market in front of so many people and it was embarrassing. And this is the thing that keeps him in the house. He's embarrassed, so he just doesn't go to the market anymore. And slowly he doesn't feel confident anymore in any crowded places and doesn't go out. So this would hardly ever look at that, isn't it? Now, another thing is this. Now, how would you feel if you fell because of these activities, going down the stairs? Would you be embarrassed? Yeah, if you're running to pick the phone and you fell, would you be embarrassed? If you're fixing a light, this one you may not be so embarrassed because it's quite like, like a superhero climbing up the ladder, fixing up the light. So you're like, I fell because I was fixing the light. Okay, that sounds pretty good, right? So again, which activities people fell from can lead to a feeling of embarrassment, later leading on to a fear of falling. Okay, so slippery floor as well. Okay, now what we do best again, exercise for reducing the fear of falling in older people. So does exercise work? So sad to say. The evidence that they found, basically the quality of the studies was low in the first place. So they were quite reluctant to comment on. They just commented on low quality study. They found that exercise intervention has got a small to a moderate effect on fear of falling. Okay, so but again, they emphasize that the studies were of low or very low quality. So what exactly is cognitive behavioral therapy, right? So this is something that fear of falling is, we need to start doing to manage this fear of falling. Basically, what we think affects how we act and feel, what we do affects how we think and feel, and what we feel affects how we think and do. Now, obviously, to do CBT, some of you might say, oh, no, I can't do CBT, I'm a physio. So that's the thing. Yeah, physio field would have expanded by now. We're all very familiar with the ICF, the biopsychosocial model, and somehow we have to include some CBT, some psychosocial aspects into our treatment. Experts will still be there, but our treatment will have to incorporate some of this. So basically, cognitive restructuring of misconceptions, basically to promote a view of fall risk and fear of falling as controllable. Okay, so this is part of it. So education on the fear of falling. We may have to spend time to educate our patient. Yes, you are fearing falling, but don't worry, this is solvable. Okay, we can work together. We can look at that issue as well, right? And also problem solving towards activity avoidance. So you know what activities are avoided, you know what environments they're not happy about. So you may have to pick up on exposing them slowly to those activity in graded levels, right? And down the stairs 10 times in your physio gym. Okay, but when he goes to a shopping center, he can't climb up and down those stairs. Okay, so do you need to expose him to staircase in a crowded environment, right? So that sort of thing. Okay, so behavior activation, I think my time is nearly over, so I'll finish up. So behavior activation and graded exposure is as well what we're looking at. So they found it to be quite effective, okay, to decrease the 6 months post. Okay, and CBT included with exercise also they found it to be quite effective. So if I can have another 2 minutes, I'll just quickly finish up on cognition. So cognition is another aspect of balance, and the more and more evidence is coming up on how cognition affects balance and how balance affects cognition. Okay, so these are the different executive cognitive, and it's been clearly shown that these functions are used in motor activities. So which means that if we improve on these functions, we'll be improving motor activities as well. Okay. Uh, So dual tasking is another aspect. So doing a one activity in combination with a mental activity. Okay, so what they found is that although the brain is aging, it still is quite plastic. It still can learn and do a lot of things. And what they found is that there may be different types of dual tasking, which we haven't really done much research about. Okay, do we do this kind of dual task? Still things that we are finding out about, but what they found is that there have been positive results on doing a motor training as well as do motor training, do cognitive training. They have found positive results on that. And in this time and in age, they've also got exercise-based computer games, which includes physical activity as well as cognitive activities. Okay, now these are some studies found, and okay, Mr. Tarun, is it my time is up? Okay, yeah, just 2 more slides. So the references are there as well. So it basically shows, it has shown promising results where it shows that there is a definite correlation between cognition and balance, which means that we have to start incorporating some cognitive tasks into our motor training as well. That may be a progression. And we will find it will be leading to improve cognitive functions as well as it will be leading to improve motor functions. Okay, hopefully, see these are two gymnasts, one the younger one, the older one. Recognizing fear of falling, confidence, as well as cognitive effects, I think will help this young lady continue to be a gymnast as she ages. Thank you very much for listening. I hope to see you all soon in maybe a physical workshop. Thank you. Okay, I'm sorry for the time.
No, that's okay. We are just not running too late, just 5 more minutes. Okay, Ms. Mahab, thank you for your wonderful and I would say a relatively unexplored area of rehab, which we must incorporate in the assessment and also in the treatment. We'll take some questions. We are getting like number of questions here, but at the end of the session, we will take those all. But for me, I would conclude with two lines here. One is studies and quantitative aspect. I mean, we need to know that what is a patient's attitude towards his problem and how he or she is feeling. It's not always with the elderly people, it's also among the young people. Like we also have shared this in our own, like when we go to the stage or podium and we sometimes fumble. So his confidence is very important. And now with your reference, what you have shared, quite number of concepts. I can say fall efficacy scale and ABC test and all, where quantitative aspect has been assessed of the domain which we call qualitative component, and students also will be raising the they will be assessing, okay, there is something coming for us and can be done. So thank you. We will have all the questions at the end of the session. Thanks again for your lovely talk. We go to the next part of it now.
Associate Professor Wee Sing Kwee's presentation is not included in this video recording due to confidentiality concerns as it contains patient videos. Thank you for your kind understanding.
And thanks for being with us. Yes, okay. Give me a minute, Prof. So now Prof. Raj will be sharing with us his topic. That's with title Research and Data Collection for Clinicians and Students.
Shall I start?
Yes, Prof, you can start.
Okay, thank you very much. So I've been given a second session to meet you all again. So happy to be with you all. And that was quite nice to hear from Madam Maha. It was like, on three different elements that she spoke, which gave us a very good evidence-based information. And with Associate Prof. Sengvi, it was a visually pleasing treat, I would say. So he had a tremendous amount of videos to illustrate the information that he wanted to give us. So thank you to both of you. And I'm happy that I was associated with both of them in the past. Not much time with Prof. Sengvi. It was for some 2 to 3 days of conference that we had invited him when I was at MASA. So with that note, I would like to proceed with my next topic. Hope my screen is visible to all.
Yes, Prof, is visible.
Thank you very much. So now, this topic is quite generic. It's not that like, I've got some written information that I should be telling you, because it is on the research and data collection for clinicians and students. So we have here two different categories. One on the learner, budding up. The other one is like a continuous learning person and a sharing person too, because on the clinical side, you will be having a lots of information. Example, you just had a lecture from our Prof. Sengvi. The amount of data that he gave us was quite interesting, because we are able to see the problems that we are only reading or speaking about. As an academician, not involved in the clinicals, I was like, feeling jealous about the clinicians' information when they have got this much of data. And this data can be transferred into research. So with that note, I would like to just introduce you to some of the approaches that a clinician or a student can take up in the form of research. Of course, yes, I'm going to come with reference to balance and with reference to evidences that has been done in vast amount over different areas of balance. So before introducing the areas that I found from the gap that I have identified through various research articles that I came across, I would like to introduce you with the approaches that you would like to take up. Basically, when I say research or when we say research, it is searching for pertinent information again and again and again, because knowledge cannot be limited. What we know is very little, and what we don't know is equal or more than the ocean that we cannot find the limits. So the clinicians or the students, both of them can take up the quantitative as well as qualitative approaches. So when I say quantitative, yes, you're playing with numbers. And when I say qualitative, you are trying to interpret the information that you have got from various samples. Or you could have been a personally experiencing person to present the information that you have experienced. Or you can be interviewing and getting the information in words, sentences, paragraphs, which we try to compile, to synthesize, which we try to bring out as the evidence from those qualitative approaches. As a clinician, you have great amount of freedom to experiment. Basically, I'm not telling that we can do whatever we want to do. Of course, it involves informed consent. It involves ethical clearance when you deal with patients, whether they are normal individuals or they are patient population, or they could be anyone on this world. When they are sampled, they are definitely your sample with their preference and not with your compulsion. So even though they are clinicians, the process is followed. But what I meant, they are free enough to have patients which a student cannot be entitled to. Yes, you're going for postings, but it doesn't mean that you will be having the freedom to experiment whatever you want, because that involves an eligibility, a qualification to go through the process of research. That is why you're experiencing the process to undertake any form of experimental studies in the near future. I'm not discouraging anyone over here, but as a matter of fact, that is what is in practice, which everyone should be able enough to accept. So the experimental designs can be of any form, and the descriptive designs can be of any form when it comes to clinicians. Whereas with reference to students, you are free enough to carry on the descriptive surveys. I could give some examples. You can be taking up some amount of balance issue that is prevalent among certain population, and you can go and explore it in a form of questionnaire or in a form of an assessment. You could get the information that you're looking for from that particular population, and you can present it to the clinicians, or you can present it to the academician, or you can present it to the world of evidence, which can be taken further into a serious form of experiment or into a serious form of survey. And then you have got correlational studies, wherein you are having the freedom to relate two different data that you have collected from the samples and see what kind of inferences you can make by those kind of correlation. Say, for example, age with reference to balance. In the balance itself, you've got many integral components which you could correlate. The video just now given during the presentation of Prof. Sengvi. There were various elements that they are quantifying into a data. You can have a retrospective study if you're able enough to assess that repositories. So those are the ways that the student can take up their own research works. Because why I'm particularly stressing on the types of designs is the practicality issues that everybody face, and we drop our research on our way, owing to the a lack of accessibility of samples and lack of samples itself. So that is not a good thing to stop a research halfway. And then we have got the qualitative approach where the clinicians can have phenomenological studies, which is quite common among physiotherapy researchers or any forms of allied healthcare. These phenomenological studies is a point where you're trying to, observe the behavior or observe the attitude or observe the perception of certain group of population or certain people who are having any kind of issue, say it could be balance or any other stuff. Then you've got, for the students, I would advise them to go for a case study, a single case study, which they can describe qualitatively in every form of the issues that the particular subject is facing with. So in this manner, the researchers can be very well carried by these two different, population. The clinicians are the students. And of course, yes, academicians can be a bridge between these and encourage such research works. And even they can be participating actively with collaborations that they have. In different countries, we have different setups. In my past experience, when I was working in Malaysia, yes, of course, as an academician, it was very difficult to have a hand on the patients, and it requires lots of formalities. Whereas over here, we do have a side-by-side practice wherein we need to work at the hospital along with the students for their teaching and hands-on. Similarly, at the same time, we also have the freedom to teach them at a classroom. So the academicians can be either way benefited. So that is something that I would like to stress upon here. And now moving on to our focus area, that is research in balance. What could be the areas of interest? See, I'm not restricting to the areas of interest. I'm just trying to focus on the areas that I was given, and from there, what could be the gap that can be identified and what kind of research works can be generated. And everyone have got their own freedom to think and come their own elements of interest or their own research focus, because the human mind is wonderful and it can have a spark anytime or it can have sparks continuously. So you can be an eminent researcher in a way that you are going to look at a problem that the society is facing with. By means of taking a research, just try to focus that you are able to contribute to the society or you are able to contribute to the profession. In what way the research that you're doing is going to contribute is the matter of concern. So in that way, with the articles that was available in the web world or in the web resources, I found these areas could be focused well, owing to the lacunae that has been identified in the previous research works that was done. First of all, talking about sensory mechanisms in static and dynamic balance, you have got a lot more to associate here. As I told you, you have got different pathways that is trying to give the input for the integral component of balance to work on the human body efficiently. So in that aspect, you can try and associate the input from the vestibular component and the visual component and the proprioceptive component. So you have got, studies that has been done and found that the percentage of contribution in the form of the static and dynamic balance varies with reference to these systems. And that I've already discussed when I was talking about that in the first session. The second one is balance assessments or training in sports persons. Of course, yes, sports person has got a very dynamic form of balance that needs to be trained, in order to improve their performance in different dimensions. So we need to be coming up with lots of innovative training that could be suiting to the to the sports specific domain. That is more important. So that's why this is another area that you can focus in terms of either you're a clinician dealing with sports person, or you are individual very interested in sports, or you are a student who can focus on them very well. So the next one, which I introduced earlier in my first session on the reactive and proactive balance training interventions. Of course, yes, when I talk about proactive, you have lots of conventional forms that you can tweak or modify in order to promote the balance training. But you have, the latest forms of equipments that can be very well used with the latest technology in order to assess or in order to train the individuals who are having a compromise. And also you can work on normal populations in order to get those values that you can standardize. And management of balance in specific condition is always an area of concern. As a person with reference to neurology or an orthopedic or whomever it could be, that area is, it's always wide open for you to explore. So with that note, I'm just trying to give you some amount of research pieces, or those researches that has been done in the recent 10 years, which can have enormous gaps, or you will be able enough to identify one or the other areas that you can focus on. So a food for the clinician, or it can be a thought of interest for the student. And as I told, try to stick on or narrow down your focus so that the research is doable and it's complete and your information is disseminated. That is more important when I'm talking about research. So the postural stability in terms of inputs from different senses was actually very well analyzed by a person, Cell, that is Timothy Cell, in 2016. He did the exact examination and he looked at the correlation and he compared the static measures and the dynamic measures. And he was able enough to bring in some amount of fruitful information, and of course with lots of suggestions to the fellow therapist. And he said that he was able enough to examine the relationship between the static and dynamic measures, which was good enough for him to, prove it to the world. And the person, Sommer et al., in 2020, he looked at the impact of bed rest on sensory motor system. So when we are talking about the sensory motor system, again, the sensory input on 3 different dimensions and motor input in the whole body. So his objective was mainly to look at how this effect of bed rest will be having its influence on the balance control. And he also looked at the mechanisms that could be responsible for all these changes. So he conducted a systematic review wherein he was able enough to get a scopus amount of literatures to work on and identify what was the impact in all these sensory motor systems. And he said that the findings of him were like, balance control in healthy individuals could be negatively affected in case if they're going in for a bed rest. If it is possible on healthy individuals, what about those clinical populations? These deficits could be accumulated and it could result in various comorbidities. So we have plenty of thoughts for us to play in this area in order to look at the sensory mechanisms that is, affecting the static or the dynamic balance. And as I was telling you about the balance assessments or the training in sports persons, you have areas of sports which is involving an extraordinary amount of balance. I think you can see those pictures. The weight trainer, does he require balance? Yes, of course. You cannot deny that. If he is not able to have the balance that he can control himself, or he can control his different body parts to put into proper postural stability and equilibrium, do you think that he'll be managed enough to carry that weight? Definitely not. So strength is integral component of the balance, which is working on those muscles. And then you can see this person who is like, surfing. Definitely there is enormous amount of balance required. And the gymnast, every area has got specific amount of studies that can be explored in detail. So I've just kept you few studies, which is looking at the balance training programs in athletes. Again, it is a systematic review, which was done by Brachman et al. In 2017. He looked at the different balance training programs among athletes, and he came to a conclusion that every every athletic performance is very, very, requiring the balance control in terms of stability as well as equilibrium. Then you had Westshore et al. In 2019. They were trying to look at the battery of balance test that could prevent the injuries. And even he came up with some amount of lacuna, telling that there is still a lot to explore because every test is looking at different domains, and we can also compare the reliability and validity measures of these tests operating on the prevention of injuries among the sports persons. Then you had Rhizomolis in 2012. I mean, it's of course a very early one. He looked at the ability to perform and the balance, how it is correlated. These are all quite a few studies that was looking at in terms of balance. Next, we are having the training interventions that could look at the balance in terms of both anticipatory as well as reactive. So in 2015, Mansfield has a study, and in 2016, Arun had a study looking at these adjustments. So I think we can just have a video on this so that it's quite interesting for you to look at what could be the domains that you will be able enough to, think about. So when I discuss balance control, this particular video can tell you how the body can react in terms of anticipation and how it could affect and cause him to lose balance if the trajectory pathway is going beyond his control. So over here, we can do subjects in order to follow these motions where the anticipatory adjustments can be brought in with different forms of balance. But if the patient is not able to control the mechanisms that is acting in between, he or she will be definitely having a fall. So this is an optimal, trajectory pathway that can be traced with the help of latest technologies. When it is being efficiently controlled. Yes, sorry, Mr. Tarun.
Lost for a minute. Please continue.
Yeah. Okay. See, you can see the video over here. If he is not estimating the catch, definitely he will have a fall. And over here, you can see the punching. If he has not done a proper anticipatory adjustments, he will definitely have a fall. So these are some of the ways you can explore different form of anticipation in the regular activities that an individual can undergo, and you will be able enough to come up with various forms of research. All these are some form of cognitive thoughts that I would like to provoke in terms of you picking up a research area. Very quickly moving on to the next video. I think Prof. Sengvi was giving us
Professor, I cannot see the video.
hello. Yes.
Yeah, I'm not able to visualize the video.
Is everyone not able to visualize the video?
May I ask? Okay, sorry, then maybe it's a technical issue.
Tarun, is everything okay?
Actually, I think everyone can't see the video.
Everyone can't see. Actually, my screen is still sharing.
Yes, no one can see the video.
How about now?
I can see the slide reactive balance training.
Yes, now.
Are you able
Yeah,
to
now we can see
view?
it. Okay. Yes, you can see that.
So that was something that, the technology is advancing and you've got a lot of scope for the research in the field of course, the equipments are not so cheap. It is very costly. But wherever you have the chance of doing it, there can be, researchers that can come up with solutions, what the world is looking for. And the area that I would like to focus next will be in the specific conditions. How do we train balance? You have spinal cord injury patients, you have Parkinson's disease, you have stroke, you have got multiple sclerosis in terms of neurology. In ortho, you've got arthritis, you've got autoimmune diseases that could affect the various joints. So you have got lots of people suffering with balance deficits. The research area can also be focusing on these individuals in order to come up with solutions that we are looking for. So some of the research articles I've even included in the reference for you to be, verifying it later as we are running short of time. So I would say that definitely research is a very systematic process and you need to be following it stepwise. You have the research question, you plan it, you execute your data collection, and then you go for disseminating the information that you have got from your research. So what for you waiting, please take it up and proceed with all kinds of success in your research pathway. So these are some of the references that I've quoted in my presentation. And I would like to especially thank to UTAR, the organizing committee, and especially Madam Maha, for inviting me to be one of the speakers in this international webinar. I'm so thankful to them. And of course, my university for relieving me officially and giving me the time to work on this and get the credit for them. And also to my family, friends, colleagues, and to my beloved students who have given me the constant encouragement for doing this presentation. Thank you so much.
Okay, thank you, Prof. Raj, for sharing us like a very wide aspect of this research. And we need to explore a bit more and need to publish those all also on a personal note. I think is very important, and you have covered quite a number of areas of like how we're going to go for assessment, how we do documentation on those. So with due respect to the time, maybe we'll proceed to the questions and we'll take the questions. So I'll request you to stop sharing the screen so we can go upon to the question and answer section. Thank you, Prof.
Yes, still my screen is sharing.
Thank you, Prof. My screen now. Okay, let's begin one segment of the webinar where we have a number of questions. We are still receiving those, but if you are still having some, you can type on the chat box on the right side here, if possible, with the name of the speaker in particular, if you wish to be addressed. If time allows and situation permits, we will still take all those. But if in case we are not able to take some of those, please don't get disappointed. You can always contact the speakers and contact, so we'll direct your questions over the time. The first question, we can see it up here, is for Prof. Raj. Does STAR excursion balance test is to evaluate the balance for the trunk? And do we use Y balance test instead of SEBT? So we have
thank
taken
you.
the question.
Yes. Can I?
Prof. Raj,
Yes,
could you
please
turn
go.
on your video as well so we can spotlight you?
Yes, both.
Yeah.
I've done. Is that okay? Is it okay, Mr. Tarun?
Maybe you can answer the question first. We'll just turn you on.
Yeah, actually, I've switched on my video as well as audio. Probably there is some delay in capturing my image. That's fine. Thanks for the questions. Yes, of course, I looked at them in the chat box. When I was telling, I quoted a particular study which was using certain tests for identifying their usefulness among this population in terms of measuring the balance. Yes, of course, I mentioned only star excursion balance test because of the article reference. You can very well use Y balance test. Star excursion balance test as well as Y balance test, both are used for dynamic balance. You can use it for the overall dynamic balance, not specifically talking about the trunk. It also relates to the lower limb. And you have an alternate of carrying out the Y balance test when your directions are limited to 3. But when you wanted to focus on multi-directions, you can very well take up the star excursion balance test. And the recent evidence that has been done in 2019 states that, of course, even with the direction measurements, both of them have having similarities and variations among the different populations that has been tested. So I would leave it to the researcher to choose among with the reference and justifications for the problems that they are going to identify among the populations that they would like to take. And with the next question, can I proceed or?
Yes, you can proceed, Prof, but maybe allow me to say that Poshal's phase considering as static or dynamic balance. I guess it is static because center of gravity remains within the base of support. We have taken the question as it is. No, nothing has been changed here. Yeah.
Okay, thank you. Thanks for that. The postural sway, when we are referring to, it is the anterior-posterior sway as well as the mediolateral sway that happens, yes, of course, when your position is static, we will be experiencing certain amount of postural sway. And this postural sway is common among all the normal individuals. But when this sway is going to be increasing in the amount, either in the anteroposterior direction or in the mediolateral direction, that is where the problem pops up. And hence, that could be an area of concern among the population that you're looking at. And yes, of course, it could be more static. And we are not talking with reference to dynamic balance here, because when it comes to dynamic balance, it is more of postural reactions than a little bit of sway that is happening during the only 2 directions. Any other information that can be added on, I'm happy to receive.
Okay, thank you, Prof, for the insight. Maybe we'll go to the next question. That's directed to Ms. Maha. Ms. Mahadevi, you have asked like how much studies being done in UTAR on fear of falling? And the second question is for you is for how do we incorporate CBT with our clients, considering our community, which may not be open to accept they have fear of falling or an embarrassment. What is the best way to approach them without being defensive? Okay, that looks interesting.
Okay, I think now you can hear me. Okay, so how many studies are done in UTAR? Frankly, in my search, we haven't even done too many studies in Malaysia. So there's a lot to be done there. And as what Prof. Raj was saying, these are some areas that's not touched upon in Malaysia. So you can pick some of these things and can be easily done as undergrad studies, all these smaller based, questionnaire based studies. So yes, so we look forward to that. Now, as for CBT, Firstly, I think physios may have learned about CBT in their undergrad. For a lot of us, it's a long time ago, and it was just touched upon. So in this day and age, this is something that we have to probably put our hands in a bit deeper. We may not be experts at it, but we may need to know some basics of it that can be incorporated as we are training our patients. So which means that at the beginning you have to build a rapport with your patient, so you might not do fear of falling, false efficacy in the first session that you see your patients. You might definitely when your patients come to you, there's so much more you have to do first. So start with that. Start with those that you're familiar with, and as you build a rapport with your patients, start doing all this false efficacy, fear of falling, and see whether you can pick out some things. Now, if the the score is moderate, you might be able to also attack those problems within your treatment, or you may need to actually liaise with a psychologist or a counsel worker or social worker who have more insight into these things to see how they can help you. And of course, another referral may be necessary as well. But the best way to approach your patients is actually to build a rapport with them. So as all of us will say, those of us experienced, once we build a rapport with them, our patients are very, very loyal to us. They're happy to wait for us for 1 hour. They're happy to do the treatments that we want them to do as well. So that's probably we have to start with. Okay, thank you.
Yeah, thank you, Ms. Maha, for the insight and giving practical input on this. We do have 2 questions. Sorry, Prof, I could get only one here, but rest I'll speak it from my handphone. The first is, the question is for Prof. Sang, that is, what are some of the risk factors associated with fear of falling? And apologies, but these questions have been later come to us. Is there any red flags commonly seen during vestibular examination and rehabilitation? And does hints need to be done in specific order? So maybe I'll repeat the second question. Is there any red flags commonly seen during the vestibular
I saw the
examination?
questions at the side,
You
so
saw it,
I
okay.
think it's okay. But since there's a question about risk factor associated with fear of falling, I think, of course, Madam Maha Devi has covered that already. Just to add on that, the visual dysfunction post-trauma can also lead to that fear of falling. What do I mean by that? We have patients who compare diplopia that can interfere with their confidence of walking around, and that can be linked to the fear of falling. Second, about oscillopsia, right? You've seen the video yourself, and I think some participants even text me and say, oh no, they feel vertiginous after watching the video. So yeah, even those with issue of oscillopsia, it can impact on their function in their ADL, and therefore that can be linked to their fear of falling. Which means if you assess a patient comprehensively, if you pick this up, then there could be interventions such as prescribing the appropriate, say, gait stabilization exercises to counteract that, and that can improve their confidence of walking, as well as reduce their fear of falling. Secondly, there are some special technique that we do in vestibular rehab to manage those with diplopia, and not with a traditional eye patch. I think Madam Maha Devi will know the technique that we use in our hospital called the binasal occlusion technique. Especially kind of designed with taping to eliminate, I'll use the word eliminate diplopia. So again, these are just some physiotherapeutic advanced skill sets that we can pick up along the way with proper training to be able to help these people. And taken together, it should help to reduce the fear of falling as well as improve their confidence and self-efficacy. Right. So now moving on to the question
sorry,
about the
Singri,
yes.
could I just add to that fear of
Yeah.
falling while you're there? And yes, those glasses have been shared with my students, the binasal glasses. So to add to this fear of falling, basically it's also been associated with they found that more females get a fear of falling. I'm not sure why. We are quite strong, but yes, that's what they found. Also, they found that people who are of older age, less education, with more chronic illnesses, poor subjective health status, of course, functional impairments and history of falls, and people who've had suffering from depression. So these tends to be also more associated with the fear of falling as well. Yeah, so that's what they found with that. Okay, thank you.
Okay, yeah, no problem. Thanks, Davy, for that. Now, so a critical question that we always consider is, are there red flags before we get our hands on patient to do vestibular rehab? Yes, in BPPV assessment and treatment, we got to rule out any possibility of VBI, because you're going to rotate the neck 45 degrees for Dix-Hallpike pass, as well as you have seen in the canalic repositioning treatment technique, that the neck will need to be rotated in that sense. So it should be contraindicated in cases of VBI, as well as those with neck problem. And you may be wondering, how about patients with cervical spinal cord injury and all that? Now, I have creatively worked around it, and David knows me well that I explored a lot of things. So I can say that with modification of the techniques, I can get around the issue of VBI. So how do I do that? Maybe I just share screen to show you this possibility. My colleagues and I have, you all can see this paper, right? Yeah, my colleagues and I have published this first paper on BPPV in SCI.
Sorry, Prof, do I need to stop sharing my screen?
Oh, yes, yes. If you stop sharing your screen, then I can share mine.
Okay.
Okay, is that okay? Now I can share my screen?
Yes, you can share.
Okay. Now, so there's this paper, in fact, it's the first in the field of vestibular rehab, whereby we treated patients with spinal cord injury using different BPPV maneuvers that you have seen. So how do we get around that? And it ties in with the reflect question that one of the participants asked. Let me just show you how we modify. So you see, we use, even those with VBI, we use a neck collar or so, and we just rotate the trunk. The key thing is not about neck rotation, it's about the orientation of the canal per se. And you notice here we have modified using a tube table to get that neck extension 30 degrees. So let me just zoom in for clarity. Yeah, I think you can see this, right? So the starting position is as such. You get a therapy assistant or therapist to help you rotate the trunk 45 degrees. And with that, you can still do a Dix-Hallpike to actually assess a anterior and posterior canal for BPPV. Now, how about treatment? So anyway, I might as well show you that for row test, that's what we do as well. You can protect the neck with a collar, and you can still do that. So that overcomes that so-called red flag of VBI, and that's why it was innovative, and we got this paper published in a high-impact journal. So how about CRT, the canalic repositioning treatment for traumatic SCI case or those with VBI issue? So again, it's the orientation of the canal per se. If the trunk has to be locked row, get extra pair of hands. And we have successfully done canalic repositioning for SCI patient as shown here. So I feel that if we're creative, if we understand the orientation of the semicircular canal, anterior, posterior, and the horizontal, therapists should be able to modify to work around that problem. Okay, so I just stop share, and I'll take the next important question about hints. Right? Is there a particular order that we should use hints to rule out any possibility of stroke? Now, if you recall my lecture, I take you through a very systematic approach in terms of oculomotor examination. First, we just stare at the eyes for spontaneousness, nystagmus, etc., etc. Now, so if you ask me about particular order, I would say that it will come in very naturally as you assess. So first, you start by looking for any skew deviation. right? And you haven't even gotten your hands on the patient, but that's good enough by observation, looking at skill division. So I would say that will be the first that you will do. Second, you will conduct the gaze evoked nystagmus test to look at any changing of direction of nystagmus. And third, finally, you get your hands on the patient physically to do a head thrust test. So if you ask me for recommendation in terms of the hints, administration, I'll propose that order because that's how oculomotor examination is carried out anyway. And for those with neck pathology or even VBI, like I said, I can even do a head thrust in that sense. So what I do is protect the neck with a collar, and then instead of thrusting the neck into 30 degrees neck rotation left and right, I actually rotate the trunk rapidly. So I stabilize the neck in addition to the soft collar, and then I will rotate the trunk and the neck as one whole lock roll kind of a maneuver to do a head thrust even. So this goes on to show that if you understand how the vestibular system works, you can still modify based on that deep understanding. So I hope I answered the two important questions about red flag as well as hints. Thank you.
Okay, thank you, Prof, for giving the, again, practical insight. Can see from your gestures and body language that you are, again, going into it. So thanks. Maybe I'll take, if there is one more question on this, if I missed during this technical concepts, what I'm looking into. We don't have further. You all still can contact our respected speakers. In the meantime, yes. Okay, so if I don't have, if you all allow me to ask some questions, what I feel. First, the question will be to Prof. Raj. I mean, Prof. Raj, can you tell us, like, because you have covered so many aspects and so many scales and all, but for being a student, when they go for assessing an elderly or even like a 50, 60-year-old, 50-year-old male, we expect them to do a lot of tests. It is not, pragmatically speaking, it's not possible. Maybe can you, I mean, like, it's very subjective and it depends on the case, but which test you feel that they must do it without fail? If they assess a person who has got some balance issue, if it's not in particular is of cerebellar origin?
Again, you answered part of your question. It is patient specific. Any forms of assessment is always based on the problems that you are collecting during the history taking and also during your observation. So what we have observed, we are trying to confirm through our examination in the form of assessments. So basically, the common test that can be used will be depending on what you wanted to look at. Is it the static balance issues that you're looking at or the dynamic balance issues that you're looking at? Is it the balance associated with the gait or is it the balance associated with function? So if it is a balance associated with function, you can easily go for a timed up and go test, which gives the information in a very short span that you're looking at in terms of functional balance. And if you're looking at a person's balance in its static form, a unipodal stance test or a Romberg's test will be giving you the information. And if you're looking at activity-specific domains, which could which could compromise the dynamic balance, you can go for, even static balance activities are also examined there. You can go for Berg balance scale. Again, you don't have time, you need to modify. The 14 points can be modified into a 7-point DBS that has been come up with the latest evidence. So these could be some of my suggestions. And again, it's not, I would state as suggestions, not as a compulsory mode of assessments. Anybody could add on? My other speakers, please.
Yeah, thanks, Prof. Raj. I just like to add on, I think physiotherapists have been assessing gait, whether it's 10-meter walk test, etc., and they're getting patients to walk forward. So I would recommend the students as well as practitioner to even consider the dynamic gait index, because now you're getting patient to walk and they're incorporating the head turns in vertical as well as horizontal directions, and also kind of stepping over a shoebox height. So I think maybe useful to consider because it's quite easy to administer. Thanks.
Yes, I do agree that dynamic gait index, even I mentioned that as one of the scales that has got its good reliability in my session that I gave just now.
So just to add as well, so again, we have many assessments.
Yes.
So it is quite pertinent to know what exactly are we assessing. And the other pertinent issue is that once we assess, our treatments has to be quite linked to the specific constructs that we've assessed. So a lot of times we find that we are assessing many things, but our treatments are not aiming at those things that we assess. So our outcomes don't improve, not that we did the outcomes wrongly, it's just that we didn't hit the correct treatments, right? And I think all of us has emphasized in each of our talks that a comprehensive assessment is needed, and I think this webinar has not been enough to cover it all, so we still need to follow up with quite a bit.
Yeah. Can I add on one more point? I actually is quite obsessed with trunk rehab. And I think when we talk about balance in this webinar, I think let's not forget about the importance of trunk control, because trunk control has been shown to be closely associated with balance, gait, upper and lower extremity kind of function. So I think practitioners should also think hard about how do you assess the trunk control that can have impact on other aspects of balance, be it static or dynamic or doing gaits. So one recommendation is zoom down to trunk impairment scale. That is a nice clinical scale to assess trunk control. So it's for the benefits of all to try out. Thanks.
Yeah, I think maybe I'll also just add one point. Very common for patient with Parkinson's disease. And I do understand we have to respect the time. So maybe one or two just more questions. Ms. Mahab, do you recommend us or as a student, do you recommend them to see this aspect apart from just doing documentation from ICF? Do you think that this should be assessed, or we should incorporate that in our usual assessment, which is already like a bit long? So do you think you should incorporate those components in
Sorry,
students' assessment?
which
The
component
fear
is
of
it?
fall, no?
Yes. Yeah, I think it has become quite important that we put it in fact, when I've been doing my geriatric module for the past, is it 6 years? I've already put in these components in, but it's still it's still skimming the surface, because we don't have enough hours to cover all of it. So students are aware they have to treat the fear of falling. They have to assess the fear of falling, but they may not be fully aware or experience how to actually effectively manage it. So we still have to put that in. I think because physios are trained at, they're becoming quite specialized. They're being trained at such a higher level. You'll start finding that a physio assessment may not necessarily be 20 minutes or 30 minutes anymore. It may be slightly longer, and it may even go over a few sessions, and that's fine, because your point is to get to the long-term goals in the end, right? So yes, it has to be incorporated, in short.
Yeah, we had some conflict earlier. We used to discuss this area, psychological domain, but yeah, a lot of physiotherapists are coming in this field. And the last question, Prof. Maybe because your interactive video has made me to feel on this. Do you recommend those exercises, even though rational should be very clear? We understand because whole day we are talking about evidences here, but do you recommend it, those exercises, walking with holding things like hand-eye coordination to an elderly person who is susceptible or is inevitable in that age where he can fall, like a 65-year-old, if you follow WHO or Those exercises are good enough?
You see, what I've shown in the video is just, like I said, possibilities for therapists to explore. Doesn't mean that patient can do it independently on their own. Some of them should be done at home under the supervision of their carer. Right, so I always emphasize safety as a first thing when they have to do any of the vestibular exercises that incorporate eye-hand coordination and balance in that sense. So that is how we should prescribe exercises in a safe way, taking into consideration the support from their carers. Right. So and knowing their home environment also give us ideas. Okay, how can I improvise certain of the environmental setup for safe practice. Say the four corners of the wall, they can be standing there, then maybe have a chair in front of them, so that the corner of the wall will catch them should they fall posteriorly, right? And the chair in front may allow them to catch hold when they fall anteriorly. And then the walls at the side can also catch them laterally if you like. So if there's a need to prescribe exercises along that line, assuming their loved ones are working, they can only spend time to do vestibular exercises in the evening, then do those that require supervision. But if they are in the day, they have to do it on their own, perhaps just prescribe gaze stabilization or others seated down, right? When they're seated down in a wheelchair or in the armchair, is very safe.
Yeah, I do understand your concern. Again, read between the line. That's a disclaimer alert that do not practice anything in your own unless you have been guided or supervised or someone is present. We agree with that. Helping us to see the environmental factor. Yes, and maybe I'll just also add, with due respect to all the speakers, that sleep may also contribute to the fall quite a lot if we sleep because an area of exploration we are also working in UTAR, so that can also contribute. But I think that's all is on our side from the question and answer session. We already reached 2 o'clock now, and I would like to conclude here. Allow me to say a few words on this. Thank you all for joining and spending your valuable time on the weekend here. And I'm quite sure that you will have, we would have learned a lot and imbibed a lot new notions and some relatively unexplored areas of confidence and all. I think that's really needed. And as Harry Keller said, that alone we can do so little, but together we can do so much. So without those who has valuably contributed in this, I couldn't afford to miss and convey the sincere thanks and acknowledgement to those. And the honorable name is Prof. Chong, Emeritus Prof. Chong is Dean FMHS. Dr. John Paul Judson, who always has been empowering us, Chairperson of CRNCD. Mr. Mohammed No Zulfikri, our head of the, who always also encourage and allow us to venture into new adventurous concepts of endeavors. And Ms. Mahadevi, who is the chairperson of this webinar, say like Brain Baby, as secretary of the event, Ms. Nandakumari, Ms. Aarti, and those all, if I have missed, apologies for that, who have been directly and indirectly are involved with this. I think I missed your name, Ms. Wali, sorry for that, for doing all this endeavor and like making this a success. For me now, I would like to call signing off. Again, my name is Tarun. It was a pleasure indeed to be a part of this whole concept. I have learned a lot on my own in person, and hope to see you all with the upcoming notions. Take care, stay safe, and I hope we can all meet without mask in this year or next year. Keep smiling. All good things must come to an end, and this is the end of this webinar. We will have a photo session here, and I think Ms. Wali will be helping us with coming in this. We'll invite all the respected speakers to be on this. Allow me to share one more information with you all. Give me a second for that.
So while we are waiting for Mr. Tarun to pull out the screen, I will also like to give my personal thanks to my good friends, Prof. Raj and Seng Hui, Associate Prof. Wee. We've been friends for quite some time, and they are very busy people. You can just Google them. You can see the publications. But when I've asked them to come and speak at this webinar, actually Prof. Raj was the one who mooted the idea at first. So thanks for that. They immediately said okay, and they were okay with the timing, and they've taken their own time out, and they've done this for us, and they've done a really great talk. So I really like to thank them for that, and really I hope we'll be able to do a hands-on workshop, either in India, Singapore, or Malaysia, where some of us can get together and really attack balance as it should be attacked. And thank you all for participating, and also thanks very much to my team members. They've been all very great. The names are there perfectly up there. So all of them, thank you.